I think we all agree that in the last few years, a lot of things have very much improved, but there are still some issues and some room of improvement. First of all, what about our risk stratification for thromboembolic events? We know all that thromboembolic events is one of the major causes of morbidity and mortality for patients with PV. And according to our traditional, conventional risk stratification, we consider age above 60, as well as thromboembolic events. And the question is, are these two risk factors of equal weight? We have very nice data coming from the United States showing very clearly that this is not the case. Thromboembolic events are much more relevant as a risk factor for a further and a second thromboembolic event for patients with PV compared to age alone. So we have to rethink our classification. Second, what about CHIP-associated somatic mutations like ASXL1? We know very well that CHIP has been long well known by cardiologists that it is associated with the risk of cardiovascular disease. And we have very nice data showing that if we incorporate CHIP-associated mutations in our risk stratification, in addition to cardiovascular risk factors and the presence of thromboembolic events, that we could almost reclassify all our so-called high-risk patients based on age alone. Because if I have an elderly patient with no cardiovascular risk factor, with no mutation, CHIP mutation, and no thromboembolic event, then this patient is actually a low-risk patient and very low probability of getting a thromboembolic event in the next few years.